Good afternoon and welcome. My name is Aida. On behalf of the Division of Healthcare Financing and Policy, I would like to call the meeting to order and verify that today's meeting agenda for the Public Option Design Session 6 was posted on January 20th, 2022 on dhhs.nb.gov and at notice.nb.gov. With that, I'd like to pass it on to Emma with Manat to go over some housekeeping items. Thank you.
Next slide, please. Great. Live closed captioning will be available during today's meeting. Click CC on the bottom of your Zoom window to enable or disable. There are a few ways attendees may participate. First, participants may submit written comments and questions through the Q&A box. All comments will be recorded and reviewed by the state. Participants may also submit comments and questions to nvpublicoption@dhhs.nv.gov. At designated times, spoken comment will be permitted. Participants must raise their hand for Zoom facilitators to unmute them to share comments. Facilitators will notify the participants of appropriate times to volunteer feedback. If you logged in via phone only, press *9 on your phone to raise your hand, listen for your number to be called, and if selected to share your comment, please ensure you are unmuted on your phone by pressing *6. If you logged in via the Zoom interface, press raise hand in the reactions area, and if selected to share your comment, you will receive a request to unmute, and please ensure you accept before speaking. Public comment will be taken during the meeting at designated times. Individuals will be called on in the order in which their hands were raised and will be given 3 minutes. Please state your name and organizational affiliation when you begin. Participants are also encouraged to use the Q&A to ensure all feedback is captured, or again, you may email comments to nvpublicoption@dhhs.nv.gov. The state has published a public option FAQ and will continue to use this resource to inform the public and address design questions. And with that, I'll pass it to Suzanne Bierman.
Thank you, Emma. Good afternoon, and thanks for joining today's meeting. Here we have an overview of the agenda for today's 6th design session. The topics that we'll be discussing today include licensure and oversight, issues and considerations around offering the public option in the small group market, an outline of the next steps in this process related to the actuarial analysis and opportunities for public engagement, and as Emma mentioned, concluding with an opportunity for public comments. Next slide, please. Thanks. So again, here we have additional information about today's meeting. This is the 6th of the design sessions, and as I mentioned previously, we'll really be focusing on licensure and oversight concerns today, in addition to questions around offering the public option in the small group market, which was a permissive decision or consideration in Senate Bill 420 in establishing the public option. So just want to give an opportunity for stakeholders to provide information on that, and also teeing up a couple of questions to consider. Lastly, we'll again go through the next steps in this process, provide some additional information on the actuarial analysis and additional opportunities for stakeholder feedback. I'll now turn this over to Ann Carl from Manat. Thank you.
Hi there. So we wanted to just give a highlight on what today's goals are. So as Suzanne has mentioned, we want to discuss licensure and oversight and really think about how oversight of the public option may be different than it is for oversight of other QHPs and what role Medicaid would have in that process. And then we're going to discuss offering the public option in the small group market. As Suzanne noted, that's a permissive decision. So in addition to thinking about the feasibility of that, also really looking for public input on the potential benefit for small group stakeholders and whether there are other strategies that stakeholders would like to see the state pursue before moving to offer the public option in the small group market. So we'll jump in on the next slide to talk about licensure and oversight. So there are different roles for licensure and oversight. Because the public option is a QHP, there will always be some role for the Division of Insurance and also for the exchange. So the Division of Insurance does the annual rate filing review, forms and binder requirements, including looking at riders for non-essential health benefits, reviews network adequacy submissions, and monitors solvency and reserves. And DOI will continue to have that role for the public option plans as well. Similarly, the exchange has a role in certifying QHPs, and because the public option plans will be QHPs, the exchange will continue to have that role. Next slide. So the next slide lifts up more what Medicaid's role would be in the oversight of the public option. So DHHS will have a unique role in that DHHS will be the one who issues the RFP and holds the contract with the public option plans. So in addition to being subject to all of the standard licensed insurance product and QHP requirements, the DHHS will be imposing some additional requirements on those public options. Some relate to things set out in the legislation, like premium reduction requirements. Other things that the state is considering are topics that we've discussed in prior design sessions, things like potentially different or more stringent requirements around network adequacy or value-based purchasing, for example. So there will be some role that DHHS will have in just managing that contract. So there's sort of two perspectives that the state could have. It could have more of a contract management and oversight role, where it really is sort of more limited in a way, or it could provide more oversight in an annual determination on whether to extend public option contracts. So that is what we're seeking sort of input from the state on, or from the stakeholders on, about whether or not the public option oversight, to what extent should it look different and what role should Medicaid have in that oversight. Next slide. Great. Okay. Then on the next is thinking about what the policies to strengthen oversight would be. So the state could have some ongoing reporting around, requiring potentially reporting of marketplace carriers to the HIE or the All Payer Claims Database to inform additional research analysis and monitoring. So one question for the public is what additional reporting might be useful, and should the state be considering adding those additional reporting requirements? And I'm noticing someone from one of our guests has raised a question, which I will say I was thinking the same thing. I'm concerned that this is different than what we had shared and uploaded for the prior session. So if we could just take a pause and make sure we have the right version uploaded.
Yeah, and I'm gonna share my screen, and I think we can go back one slide and then move forward. Does that sound okay?
That sounds great to me. Thanks.
Julian, do you mind if I share my screen? All right, Anne, I think we're back on track.
Okay, great. Thank you. This does definitely look more like what I had thought it was supposed to look like, so thank you. Okay, so this just again lays out what we had talked about before. DOI has a role, Exchange has a role, and Medicaid has a role in that it controls the contract. So then on the next slide, this is talking more about what Medicaid's role in contract oversight would look like. One key example would be if, we've heard consistently throughout the design sessions that there's networks are a real challenge. And so that there could potentially be a different way to either different network adequacy standards or potentially different ways of reviewing whether there's sufficient network adequacy and DHHS might have a role if it goes, above and beyond what would be required of qualified health plans, that DHHS would be tasked with monitoring that. Again, this is all things that the state is still taking under consideration. So interested in public input on that and what the areas for additional oversight would be, where you would sort of like that additional layer of scrutiny, networks, provider payments, others. Next slide. This was what we had been discussing. So I think this largely touches, we sort of touched on this already. So question about should there be additional reporting requirements on public option plans that go beyond what marketplace qualified health plans are normally required to do. And then another question is, recognizing that now there will be 3 different state entities that have some type of oversight role, to what degree is it important that there is an effort to streamline some of the reporting, financial reporting in particular? And are there any things that are sort of related in the Medicaid space that, to the extent that federal law permits it, that folks would like to see imported in? So network standards, differences around quality or MLR in lieu of services, those types of concepts from a Medicaid managed care standpoint that could be carried over, again, to the extent that you're able to reconcile that with federal requirements related to QHPs. Interested in public input on all of those questions. The next topic I'll touch on is offering the public option in the small group market. So this is something that the legislation gives the director of DHHS the authority to make the public option available to small employers in the state. There are some considerations about whether or not this makes sense to be doing in the short run. So what are the trade-offs to offering the public option in the small group market? Is this something that would really be beneficial to small employers? Are there other strategies that the state could pursue that would be more advantageous? So any thoughts on that, or any specific stakeholder engagement processes that should be considered when the state is thinking about whether or not to offer the public option in the small group market? Next slide. Okay, those are the substantive topics that we wanted to cover for today, and I'll just take a minute to preview where things are going from here. So the first is the next steps in the implementation timeline. At our very first design session, we had shown you this, laying out how we got from this past fall all the way through to the target launch date for the public option in January of 2026. So we're now entering the second phase, which will be the Section 1332 waiver application development. So that includes drafting the waiver application itself. A critical component of that is the actuarial analysis. We'll talk about that in a slide or two. Additional stakeholder and policy engagement. My colleague Julia will speak to that in a couple of minutes, and a state public comment period. So this will be a year of work targeting a submission date of February 2023. And of course, all of the state's work will be informed by the really helpful feedback we've gotten during these design sessions. Next slide. So key deliverables during this next phase. Actuarial analysis. I know this is an area of real interest. We'll talk about it a little bit more about what exactly will be included in that actuarial analysis. A stakeholder outreach plan and 2 public hearings to receive public feedback on the draft application. A public presentation of actuarial findings and waiver updates. A draft application that's posted for public comment for at least 45 days, and then a final 1332 waiver application that incorporates the feedback that will be submitted to CMS. On the next slide, just wanted to highlight a bit more about the actuarial analysis. So the federal government requires that states submit actuarial analyses and certifications to support the state estimates, but the waiver will comply with federal requirements. As we talked about in one of the first design sessions, one of the key requirements is, for example, that waiver be budget neutral, also that coverage be as comprehensive. So there's a set of guardrails that the state is required to demonstrate that it meets, and the actuarial analysis is really critical in doing that. So the process will be that the state is currently collecting market and financial data. The actuaries are about to begin their work to do the actuarial analysis, and then the actuarial team will develop a written actuarial briefing document summarizing the 10-year projections. We note that the legislation expressly requires that the waiver analysis take into account the effects on premiums in the state with and without the new provider participation requirement. So if you recall, the legislation requires that providers who are participating in PEB, Medicaid, and workers' comp also participate in at least one public option plan. And so the analysis will need to take into account what that provider participation requirement is likely to do to premiums. So there'll be, of course, a lot more to come on the actuarial analysis, and I'll turn it over to Julia to talk about stakeholder engagement, which we'll also highlight when we're going to be getting input from you all. So thank you so much.
Great. So there will be many opportunities in addition to this one for the public to give input into the development of the 1332 waiver. There's going to be a public presentation of actuarial findings that's also going to include waiver updates. The input provided by the public during that presentation will inform the development of the draft 1332 waiver application. When that is released to the public, that will kick off a 45-day state level public comment period, during which the state will accept public comment on that draft waiver. And we'll also provide 2 public waiver hearings that are going to be hosted by DHHs, during which time the public may provide comment. There's also already a state public option website, which includes the public option frequently asked questions mentioned earlier, and a place where you can sign up for a notification email list to receive regular updates from the state on the process. So if we go to the next slide. Also on that website, there's going to be a project dashboard that's going to provide the public with information on the status of the development of the public option. This is the 6th and final public design session. In the spring and summer, that's when the process of the actuarial findings and report are going to take place, with the 1332 waiver development to take place this coming summer and fall, including that comment period discussed previously. And then finally, there'll be submission of the 1332 waiver to CMS. So a couple of recent updates. As we noted, the FAQ has been released on the state's website. There will be a summary memo synthesizing the feedback received at these design sessions. And there's also going to be a tentative schedule posted for the timeline for the actuarial findings and the public comment period. If we go to the next slide. Suzanne, do you want to jump in here? I don't know if you want to make any remarks before we invite public comment.
Thanks, Julia. No, I think we're good to go straight into public comment. Thank you.
Okay, great. First, I will call on Barry Gold. Barry, you should be able to unmute now.
Yes, thank you for the opportunity. For the record, my name is Barry Gold. I'm the Director of Government Relations for AARP Nevada. This has all been very interesting, and I've enjoyed the opportunity to participate. However, all the meetings that I've been at and offered public comment in, the people who have participated on this aren't really the public. When I think of the public, I think of the little guy. It's been providers, it's been trade associations, it's been industry representatives, it's been a couple of advocacy groups, it's been chambers of commerce. That's who I see who has submitted comments, who has provided public comment, and that's all well and good. But what I mentioned at the very first meeting, there's this, if we build it, they will come philosophy. And that's really, really scary and dangerous. And I think we need to make sure the way that we can get John and Mary Q Public to figure out what this is about, because when you use the word public option, The word public option has been indoctrinated to people, and it's become very polarized. There are people that think this is the best thing since sliced bread, it's going to lower the cost of healthcare. And there are those people that think this is absolutely a socialist takeover, government takeover of healthcare. So I think there needs to be some outreach to the average little guy as to what exactly the public option is and is not, and how to do that. So I look at the opportunities for public input, and I see public presentation of actuarial findings and waiver updates. Don't think that's going to attract a lot of individual people. The next one is 2 public waiver hearings. If you don't know what that's about, you're not going to go, and I'm kind of wondering what they're about right now myself. So I think these are great things, and you're going to get some great input, and it's going to be inside baseball. And I think we need to avoid playing inside baseball because, again, when it's built, when we build it, we want them to come. And so we need to make sure that we include those. So what I would highly urge and suggest is you hold some focus groups with the average little guy and little gal and ask them what they think and what this is about, and give some information so people will have a little better idea what this really is and is not. So again, those are my public comments. I appreciate the opportunity on behalf of the 345,000 AARP members across the state to discuss the public option, which AARP believes will increase access to affordable quality health care. Thank you.
Thank you for your comment. Next, I will call on Harpreet Tsui. You should be able to unmute now.
Thank you for the opportunity to share my thoughts as a healthcare provider on the implementation of Nevada's public option. For the record, my name is Harpreet Tsui, spelled Harpreet Tsui. I'm an internal medicine physician and I live in Henderson. Some of the most heartbreaking moments I've experienced as a physician are when I see patients who suffer an advanced chronic condition that could have been managed or treated had a doctor seen that patient sooner. All too often, I hear patients tell me they couldn't afford health insurance. They couldn't pay for out-of-pocket medical costs, which led them to delay and sometimes ignore healthcare altogether. By the time we see these patients, their conditions have worsened, treatment becomes more complicated and more costly, and their outcomes are severely compromised. Cost is a barrier to care for too many Nevada families, and no family should have to ration care. Nevada's public option inspires hope for many people by enabling them to access affordable healthcare and see a doctor earlier. The public option is a path for people who have fallen through the healthcare cracks to live a full and meaningful life. By making healthcare coverage more affordable so more people have healthcare, Nevada's public option can also reduce incidences of uncompensated care, which affects the ability of many healthcare facilities to stay open and continue to serve their communities, especially those facilities that are serving vulnerable populations. Nevada's public option benefits patients and empowers providers like me to do my job of saving lives and protecting health. The pandemic has only exposed the glaring gap in healthcare outcomes between uninsured and underinsured individuals who struggle with chronic conditions, with those who have access to regular care and can better manage their health. We can close that gap, improve health, and save lives. Thank you for your leadership in making Nevada's public option a reality and for the work to implement a program that will benefit all Nevadans. Thank you.
Thank you for your comment. Next, we'll call on Helen Foley. Helen, you should be able to unmute now.
Yes, thank you. This is Helen Foley, and I am representing the Nevada Association of Health Plans. And while we plan on submitting our letter on the small group market and the timeline of the 1332 waiver, we want to stop for a moment and congratulate the state of Nevada in enrolling over 100,000 Nevadans in Nevada Health Link. This is a 25% increase in enrollment from last year and is the highest enrollment since the exchange began in 2019. Additionally, there have been increases in the number of people covered by Medicaid, but based on your previous presentations, there are still 37% of those eligible for Medicaid who are not enrolled. We believe that an aggressive facilitated enrollment could be very effective in enrolling eligible Nevadans in Medicaid. This was accomplished quite effectively during the Gwynn administration when Nevada Checkup was created. Getting out in the community and explaining the product made a real difference by dramatically increasing enrollment. The same occurred with navigators during the ACA rollout, and this could also happen and should happen with Medicaid. The question must be asked, if individuals are eligible for free health insurance through Medicaid or the reduced rates through the health exchange, and yet they aren't enrolled, why would we ever think they would enroll in the public option that is going to cost them money? And who is the state targeting for the public option? Who is not already eligible for free or reduced costs through Medicaid or subsidies through the exchange? The answer to these questions we continue to ask these questions, but the answers are elusive. We will continue to work with you throughout this entire process, and we certainly hope to find the very best solutions to Nevada and to Nevada's residents. Thank you.
Thank you for your comment. Next, I'll call on Dean Pulse. Dean, you should be able to unmute now.
Yeah, my name is Dean Pulse. I'm an anesthesiologist, and I represent the State Medical Society as well as my anesthesia group, which is the largest group in Nevada and cares for 100% of the cardiothoracic patients in Southern Nevada. I know the comments have come before from organized medicine, but by and large, organized medicine, and especially people who work in critical care, our emergency services don't support a public option any more than they support an expansion of Medicaid. And if you say, why is that? Over the last 20 years to 15 years, rates have either dropped or gone down to a point where they're not sustainable to maintain practices. As the internal medicine doctor spoke before, she may have options on limiting who she sees in her clinic. I don't have any, neither do my partners. So anybody who presents for emergency services, we take care of them, no questions asked, and deal with things later. So I don't know how far down the road everyone wants to go to get, quote, stakeholders involved in expanding another government payer. But for the emergency medicine doctors, the radiologists, the ER physicians, orthopedic surgeons, cardiothoracic surgeons, heart surgeons, et cetera, there's not much appetite to expand any of these products. So we made these comments known and were frankly ignored during session. And now there's public comments on it. So we want to make sure that we attend these on a regular basis to say that the people who actually are charged with doing not only the tough work, but the yucky work in the middle of the night on their critical patients, this is really not a sellable plan for us. I'm happy to take any questions or feedback, but heretofore we haven't spoken up as much. But we are aware of this bill. We're very disappointing in not only the passage of it, but how it went down. We're happy to help take care of patients. We do all the time, but it's not sellable to say do more and then raise malpractice rates and have another product that just doesn't pay for services. So I appreciate everybody's time and hard work trying to find a solution to a complex problem. But this is not going to solve anything, just to be candid. Sorry.
Thank you for your comment. I will now call on Patrick Kelly. Patrick, you should be able to unmute.
Good afternoon. My name is Patrick Kelly. I'm the CEO of the Nevada Hospital Association. Oversight is critical to the success of the public option program in Nevada. SB 420 requires the director to operate the public option, and it allows the director to contract with a third party to administer the network. Any delegation by the state must be carefully monitored to ensure that the narrow parameters allowed by the legislature are followed. Nevada has a fragile healthcare delivery system. The last 21 months of COVID have clearly demonstrated that. The state cannot hand over administration of the public option to a third party and hope for the best. It must be proactive in its oversight of the program and the delivery system. Too many things could potentially go wrong, from major disruptions in the insurance markets to driving away healthcare providers. When problems occur, they must be identified quickly and acted upon swiftly. Nevada cannot take a wait-and-see approach. Access to care continues to be a huge problem throughout the state. Our healthcare provider network must be robust. Skinny networks lead to many problems, including inadequate access, delays in appointments, long travel requirements, and large out-of-network bills for consumers. That's why we believe it's important to have many physicians in the networks in every emergency room in the state. These large networks should be required to timely respond to patient needs. To achieve access and affordability, the state must focus its efforts on producing more physicians, nurses, and medical techs. The current supply of healthcare providers is inadequate. Community involvement is also critical to the success of the public option program. State citizens should be surveyed to identify changes that can promote better health. A survey and independent analysis should be conducted to understand why tens of thousands of eligible people don't participate in free healthcare programs. Such a review may identify flaws to avoid. Stakeholders should be provided an opportunity to review and comment on the two actuarial studies. Face-to-face dialogues with give and take are important to developing the best public option program for the state. The approval process by the Division of Insurance also must be open and transparent. All individuals and entities affected by the public option must have the opportunity to observe and comment to assure a sustainable program. Many thoughtful people are needed to make this program a success. Thank you.
Thank you for your comment. Next, I will call on Stacey Sasso. Stacey, you should be able to unmute now.
Hi, my name is Stacey Sasso, Executive Director for the Health Services Coalition, representing 25 employer and union-sponsored health plans in Southern Nevada. As we've previously commented in the other stakeholder meetings, our groups remain concerned with the impact of the public option to our plans and to the community and access to healthcare. We still remain confused on the population that this is targeting and who would be able to enroll that has not already had the opportunity to enroll in other plans being offered. Our actuarial evaluation that we've done internally has been completed, and we'll be submitting details to the committee later this afternoon for review. We appreciate the additional stakeholder meetings that will be scheduled, and we look forward to continuing to participate. Thank you.
Thank you for your comment. At this time, I do not see any other hands raised.
Thanks, Emma. If there are no other comments, we'll adjourn today's 6th design session meeting. Again, want to thank everyone for participation and providing comments. Thank you.
Thank you for joining. You may now disconnect.